Good morning, everyone, and welcome to our February staff meeting. For those new faces here, my name is Michael Brubaker. I am the Associate Director of the department. The first thing on the agenda today is to talk a little bit about falls in the ER. The reason for this, we've noticed an increase in falls in the recent quarter of last year, and it's a little bit alarming that the increase in falls that we've seen. Of course, we know that all of the information from falls is put into the risk management module, and then we review those on a case-by-case basis. So I just wanted to first provide you a little bit of data, and then we'll talk a little bit about our action plan, what we're going to do to try to reduce those falls in the department. So for last year, the quarters are a 3-month period, and we usually track the data in that, a 3-month period time. So for 2017, the first quarter, we had 6 falls, so 6 falls in the first 3 months of last year. The second quarter, we had 5 falls, and the third quarter, we had 7 falls. Now, that's typical for our department. We see, on average, 220 patients a day in the ER, so that's pretty typical numbers for our falls. However, in 2017, the last quarter, so the last 3 months of the year, we had 16 falls. So quite an increase there. Some of that can be attributed to our increase in volume. We know we had the surge of flu patients, so that certainly had more patients in the department. And then also we had increased admission holds in the department. That's typical for that time of the year and early parts of the year as well. So that definitely could have had an impact on the number of falls, but still, however, we feel that that's a large amount of falls and, with injuries to our patients. So we really want to focus on that, and we want to get that number down. So like I said, we track those falls case by case to look at outcomes and then talk about potential for preventing those falls in the department. So out of the 16 falls, 11 of those were fortunately without injury. However, 5 of those falls did require additional treatment, diagnostic testing, and in some cases extra monitoring as well. So what we want to do is really focus on these patients, see if there's something that we can do to kind of highlight it and make it a little bit better and decrease those falls in the department. So we're going to start a new process in the department. It mostly won't impact the majority of the staff. The biggest impact will be on the charge nurses and what to do in certain situations. But it should be an easy process. I think that it'll help us really review those situations case by case with the nursing staff and be able to make an impact on reducing those numbers. So the new process, when a fall occurs, when management is on site, so we have our day manager, also the director, and I'm there as well. And then we have the evening clinical manager that's there. So when one of us are in the department, the process will be the same initially. So if the tech walks in the room and you find a patient has fallen, then you contact the nurse or the charge nurse immediately. Same thing for the staff nurse. If you walk into the room and your patient has fallen out of the bed or whatever, contact the charge nurse immediately. They will notify the physician, and then they will also notify the manager that's available on duty. The manager will then fill out a new fall assessment analysis. That is basically a tool that reviews the circumstances of the fall, kind of how it happened, if there's any opportunity that we could have seen to prevent that patient from falling. Maybe they didn't have their call light, maybe their side rails were down, or maybe they didn't request assistance going to the bathroom. We identify those potential reasons for the fall, and then we review that with the staff nurse of that patient to see if maybe there's something that we could have done to have prevented it, and just provide some real-time feedback right when it happens so that we can evaluate if we have area for opportunity in the future. The same process is is pretty much going to be for after hours. However, if a manager is not in the department at the time of the patient's fall, you will just contact the house supervisor to fill out the post-fall analysis tool. They're very familiar with those forms. They already follow this process on the floor, so they're used to doing this. So, like I said, we'll take those post-fall analysis and we'll review those. We can review them at huddles with the staff. And it's not to be punitive, it's just to see if there's some opportunity we have to prevent future falls. It's good to provide that information to all staff so that they can look out for those things in the future, and maybe it will help us reduce our numbers of falls. So in summary, we will be for the daytime hours when a manager is available. Just when the fall occurs, the charge nurse will just contact the manager on duty. They'll fill out the post-fall analysis. If the manager is not available, then they'll contact the house supervisor to do that. Then we'll provide the feedback to the staff where there's area for improvement. So if anyone has any questions, please feel free to reach out to any of the management team. We will provide you with feedback on this and answer any questions that you have. Also in the future, if you have any questions, we're more than welcome to discuss that with you. We'll also be following up with some more data. So we want to really make sure that we're providing you, if we make an improvement on this, we want to let you know that we're making an impact on this. So we will provide and continue to talk about in future meetings this year our fall data. So you'll be hearing a lot more about that. And I just want to thank you all for all the work that you do towards patient safety. I know we do a lot that really is great for our patients, and we just have to make a little bit of improvement in this area. So thank you very much.